So currently for body dysmorphic disorder, there are actually no FDA-approved medications, but there are basically currently first-line medications that we use. The first-line medications we use are known as serotonin reuptake inhibitors. And in particular, we use a specific type of serotonin reuptake inhibitor most often, which are called the SSRIs, or selective serotonin reuptake inhibitors. And those include drugs like fluoxetine, fluvoxamine, sertraline, escitalopram, and citalopram. There's no current evidence that any one of those drugs works any better than any other of those drugs for BDD, although sometimes in an individual, one will respond to one and not to another, and we really don't understand kind of why that is just yet. SSRIs are usually really well tolerated, but there are some side effects that people have. The most common early side effects are some nausea and some stomach discomfort. That usually goes away within a few weeks, and if you start at a low enough dose, it's not much of an issue. The big long-term issues that come up for people that make them sometimes quit SSRIs are sexual side effects and some mild to moderate weight gain. And so if people do kind of have issues with SSRIs, those end up being the two main ones. SSRIs are actually also the first-line treatment for disorders like depression and all of the anxiety disorders. One of the differences in how we kind of use them in body dysmorphic disorder is that the dosages that we use in body dysmorphic disorder tend to be a lot higher than those used for anxiety and depression, and the duration, how long it takes for people to have a response, is typically longer. Often could take up to 12 to 16 weeks. This is kind of similar to how we use SSRIs in the related disorder OCD. Currently, what we know about SSRIs and how they work in BDD is they don't just help with the discomfort or anxiety. They actually help with the obsessive thinking, like constantly thinking about one's appearance, as well as kind of helping with the compulsive behaviors, something like mirror checking. And so they're useful to really hit the target symptoms of BDD, not just the things kind of caused or the emotions caused by BDD. Right now, currently, we tend to use them, again, at higher dosage and for longer periods of time. One of the things we know is that for BDD, people often have what we call low insight. Sometimes to the point of being delusional, of truly believing that their BDD symptoms are real. And they actually don't believe it's a psychiatric disorder in any way, shape, or form. They think there's actually something wrong. Other people have a little bit more insight. They kind of think that there's an appearance issue, but they also know that in some level they have a disorder. One of the interesting things is we would think that SSRIs wouldn't work as well in people with really low insight. But it turns out that actually SSRIs work just as well with people with low insight as with high insight, which is not something kind of we really expected. SSRIs, again, are typically kind of well tolerated. They usually for BDD often need to be taken for long periods of time and sometimes for life. One of the things that we've seen in some studies is that when we stop an SSRI in somebody with BDD, there's often over an 80% relapse rate. And so this is something that we pay really close attention to. So an important point is that medications are never used alone in the treatment of body dysmorphic disorder. Actually, in many ways, one of the strongest treatments for body dysmorphic disorder is cognitive behavioral therapy. And that uses a bunch of different types of form of behavioral therapy, including exposure and response prevention, and also what we call perceptual retraining. And this is a really strong treatment. One of the things that often is required of me as a person giving medication is to start people on medication to get their symptoms low enough and kind of turn down the volume on their symptoms enough so that they can actually really do the CBT, which is really hard and actually can be really difficult. And so often therapists will send people to me and they will tell me, can you help them kind of lower the volume of their symptoms a little bit because they can barely even kind of listen to what I'm saying because they're in so much distress. We also sometimes pair SSRIs with other medications. Probably the most common augmenting medication we use comes from a class known as the atypical antipsychotics or second-generation antipsychotics. It's always important to realize people sometimes get nervous when you tell them you're going to put them on an antipsychotic. Their first question is often, wait, do you think I'm psychotic? Often in kind of psychiatry and psychology, drugs are kind of given a common name based on what they are first used for. For example, the SSRIs were first used for depression. And so we often sometimes just refer to SSRIs as antidepressants, even though they're also the main treatment for OCD, BDD, and anxiety disorders. In the same way, antipsychotics were first used for psychosis and disorders like schizophrenia. But now atypical antipsychotics, especially at lower doses, are used for disorders like body dysmorphic disorder, OCD, depression, and anxiety disorders. Currently, there's a little bit of research to show that they can be helpful, and then other parts of research show that they might not be as helpful. They're kind of used often because patients have low insight, and the thought was that maybe this will help with kind of the insight into kind of seeing their disorder. The most researched ones at this point are probably aripiprazole, olanzapine, and risperidone. And those, again, are used at much lower doses than when we use them for BDD, as when we use them for schizophrenia when the dosages are much higher. That said, there are still some adverse effects. The ones we're most concerned about are called Metabolic Syndrome, which is where some people will both gain some weight and will find that their cholesterol levels, especially their triglycerides, go up, as well as an increase in fasting blood sugar or prediabetes. So we monitor for this anytime somebody's on a second-generation antipsychotic. The other kind of concern is something called tardive dyskinesia, which are kind of abnormal movements that usually happen after a long period of time on these drugs. Again, these risks seem to be somewhat lower when we're using the lower doses, but still present and need to be monitored for. So often when people have never been on medication before, especially psychiatric medication, they have a lot of concerns. One of the biggest concerns is this going to change who I am? Is it going to change my personality? Am I going to be able to feel things anymore? And often kind of their concerns are understandable, but actually what I often explain to them is often the medication actually helps the real them come out. Because often the real them has been overshadowed by their disorder, by their anxiety, by their depression, by their BDD. And often using medication to decrease those symptoms actually finally gets them towards feeling like themselves again and allows their real personality to come out that has been gone for a long period of time. One of the things that people ask often is, how do you choose which of the SSRIs you're going to use? And there's no real science behind it. And again, there's no evidence that one works better than another. But one thing we know is they often do have different side effect profiles. For example, a drug like Paxil or paroxetine, which is an SSRI, often kind of causes the most weight gain. Now, we can see this as a negative effect, and a lot of people would. But then if we also have somebody with body dysmorphic disorder who's also very depressed and is not eating, actually the side effect of weight gain can be really good. And so we're kind of somewhat tailoring people not just to the effects of the drugs, but we're really looking at the side effects of the drugs. Which side effects will bother them most? Which things aren't of concern? Once we do kind of pick an SSRI, usually we want to get them up to a fairly high dose because we know those dosages tend to work, but we want to do it slowly so they don't get any adverse side effects. Once I'm at a dosage that I think could possibly work for the disorder, then often I'll stay at that dosage for about 4 to 6 weeks. Usually if a dosage is going to have an effect, usually within 4 to 6 weeks, I like to see some improvement. And that might be very minuscule improvement. It might be just, the thoughts are a little bit less and, my anxiety is a little bit lower. And if I see an improvement, I will often then give it another 4 weeks and see how they do. I think the mistake sometimes people make is people are improved at 4 weeks but still have symptoms, and then they think, well, then I'll increase the dose. And then a month later, they're even better. But are they better because you increased the dose, or were they kind of headed in that direction on the dosage you had them on already? And so often I will kind of check in monthly to see if there's movement, even slow movement. If I see a month or more where there's no progress at a certain dose at all, I'll often get the sense that probably this is their benefit at this dose, and at that point I'll consider going up. And usually deciding how high we go up is kind of more of an art and kind of combined with some science. We want to get them to the highest dose that will be the most effective for them, without causing the most adverse side effects. And that really is always what we're doing with medication, is trying to balance those two things, kind of the side effects versus the positive benefits. And when people do get side effects, we can often treat them. And so we have a number of methods to treat issues when people get sexual side effects or sometimes get weight gain.